And thanks so much to all the support IHA has given Health News all over the years. And with that, I want to jump right into discussion. Peter, I'm going to start with you. I always like to start with the person next to me. I apologize in advance.
I knew it. Strategic.
As has already been mentioned, healthcare affordability has really come to the forefront. According to a recent KFF survey, just under half of U.S. adults say it's difficult to afford healthcare costs. About 3 in 10 say they or a family member in their household has problems paying for healthcare. A separate survey by KFF found that healthcare costs continue to be the public's top list of affordability worries headed into the November midterms. So, starting with all of that, Peter, I guess just to kind of start off the conversation, what do you think are some of the main drivers of healthcare cost?
Thanks, Ryan. Thanks for having me here. I really appreciate it. Thanks everybody for attending. I think as far as the pharmaceutical industry is concerned, I think rising out-of-pocket costs has been the biggest concern by us. Honestly, we've had a lot of consolidation in healthcare, everything from insurers buying up pharmacy benefit managers, buying up specialty pharmacies, buying up mail-order pharmacies, in some cases buying physician groups, and even some hospitals as well, the for-profit hospitals, and that's created a lot of consolidation and less competition among price. But honestly, one of the big things we've been worried about is the pharmaceutical industry basically spends $350 billion in 2024 alone on rebates and discounts on drugs, and very little of that is actually getting to patients. And that's something that we've been trying to change for years by having those rebates be passed on, or more of those rebates being passed on to patients at the pharmacy counter, regardless of what kind of healthcare plan they have. We've seen a lot of costs go up with high deductible healthcare plans, which have become more and more prevalent since the ACA. When high deductible healthcare plans were created, the deductible was $1,500 for a family, and now it's 3, 4, 5 times that. And I mean, honestly, just to say in a press release that an insurer can put out and say, but our premium stayed flat. Well, that's great that your premium stayed flat, but it's still a much larger expense coming out of everybody's pocket every day. So I think the minimum that can be done is returning some of those rebates and discounts that they negotiate with us back to the patients, either in the form of just a straight up discount at the pharmacy counter, or even lowering their deductible if they could.
Thank you. Dr. Shanley, what about you? What do you think are some of the main drivers of healthcare cost?
Thanks, Ryan. First of all, again, thank you for the invitation to participate with the panel, and all of you for showing up. And I think before I want to give the context a little bit, maybe we're a little unique at Lurie Children's Hospital. We're the only independent freestanding acute care children's hospital in the state. And we are responsible from a mission standpoint in the clinical care that we provide, and we take care of the most complex patients in the state. 60% of those patients almost are covered by the Medicaid program. And in addition, we drive research, which you all want, to make sure that kids are getting the frontline care and the cutting edge care that advances things. And we'll talk, I'm sure, about workforce. And the workforce, anybody who has good news on the healthcare workforce, raise your hand, I'd love to hear that. So, and in particular, it's worse and accelerated for pediatric subspecialties. Okay, so if you're gonna ask me to do the mission, my job is to make sure I have a business model that is sustainable to be able to do all that. And so that business model is what I get reimbursed versus what the cost of doing all those things is. And now, just for a second, remember, since we are so dependent on Medicaid, healthcare, by the way, is outside of public education, the only thing that doesn't have inflationary pass-on capability. I can't tell Medicaid to pay me more because it costs me more to hire people, costs me more to buy drugs, costs me more to provide cybersecurity, costs me more for med malpractices. So these are the drivers. I hope we'll get into some details in terms of why those cost structures have gotten so high. But these are all external to my hospital and to the health system and to my peer hospitals. These aren't things we're driving in terms of the costs. We have to be reactive to and have a sustainable model to deliver on our mission. So I think our biggest value is our workforce and challenges in terms of making sure that we can compete with that. And we compete at the national level with our peers in the top 15 children's hospitals in the country. We still want to make sure that we can educate them. We should talk about education programs at the federal level. That would be interesting since we get screwed on that as well. And if the government is going to decide not to fund biomedical research anymore, then we just need to know we're going to continue to need to invest in that if you want us to be at the forefront of medicine in America today. So those are just some of the things I see as external factors that drive the cost structure.
Thank you. Dr. Shanley, I think you gave us a preview of a lot of today's conversation, so looking forward to it. Blake, just kind of what are your thoughts? What are some of your perspective on kind of what is driving these costs?
Yeah, first off, thank you everyone for being here. A pleasure to be on the panel with distinguished guests that we have here. I'm Blake Evans. I'm the Assistant Vice President of Revenue Cycle at Rush University Medical Center, Rush System for Health here in Chicago. And so to Dr. Shanley's point, not only are we dealing with patients who are part of our local community at Rush, right? But if you think about being an academic medical center, you attract some of the most critical sickest patients that need critical care. They come to our organization. So I'm going to speak to it from maybe a little bit of a different lens, more from a revenue cycle perspective. We are on the front lines trying to work with the payers, the patients, to try to get claims paid, reimbursement for the hospital, all of that. And all I would say is that if you can think about the complexity of all of those efforts in terms of patient coming in for care, right? We have so many different payers that we work with. All those payers have different rules and how things work. There's prior authorization processes. There are a number of things that, go through that process to get a patient seen, treated, and then also get the claims paid. And so what we have noticed is that our patient population is getting older, right? I think that's true across the U.S. The patient population is getting older. And as you look at most payers, Medicare is one that has probably the least, I would say, administrative burden to get a claim paid. But you have a lot of patients that are going to Advantage plans that has the reimbursement of Medicare, but the complexity of commercial insurance, right? So if you think about the cost of that, but the lower reimbursement that you're receiving, that creates some challenges as well. So I would say the sheer complexity, whether it be from a hospital perspective, from pharmacy perspective, from a payer perspective, that complexity, I believe, is really the true nature of what the cost is all of those networks working together.
Thank you so much. Dr. Robinson, are you able to hear us right now?
I am. Are you able to hear me?
Perfect. Great. That's able to work. Dr. Robinson, I was just curious to kind of your thoughts on this from the insurance perspective. What do you see as some of the main drivers of healthcare costs?
First, let me say good morning to everyone. I apologize to the audience and the panelists for not being there. I had flights canceled yesterday, rebooked, different airline, different city, different route, and getting home 24 hours later. So sorry I'm not there with you all. Great question. I think, first of all, I would say that, collectively, I think the larger we needs to do a better job at keeping Americans healthy, focusing on prevention, early detection of disease, and that's going to allow people to have a better quality of life and lower long-term cost of care. The reality is that we do have a higher prevalence of chronic diseases that are preventable. We also have this intersecting with a period of time where there's a lot of distrust in institutions and even in healthcare. We see that with vaccines, for example. And so you have individuals also that are presenting with later presentations of conditions that are going to be more costly to treat. But we also have the intersection of a lot of new therapies that are available. We have cures to some conditions that we once deemed incurable. I think when Dr. Shanley and I were coming through med school, we didn't really see sickle cell as being a curable disease. New minimally invasive surgeries, novel treatments with really great promise, new imaging techniques, advanced genetics. That's not a lot of things that are occurring to innovate in healthcare, but the raw cost and prices of those are unaffordable for most Americans. And so I think part of what we're all grappling with on the panel today is that we've seen healthcare costs continue to outpace inflation, other sectors of the economy, and there's a lot of forces, whether it's trying to recapture R&D costs or capture the potential future savings from new treatments or fixed costs of facilities, supply chain costs, wages. All these things come together and they tend to outweigh that shared imperative for humanity and affordable access to care that I think we all are committed to. And so I think those are some of the big drivers of healthcare costs that we're trying to address today.
Fantastic. And Dr. Robinson, I want to stay with you. Just what are some of the steps that organizations like HCSC are able to take to address healthcare costs?
Well, one of the things that we've done is we've got a long history in the value-based care space. Our HMO product there in Illinois is one of the well-known VBC programs across the country. But a lot of great efforts in that space. We've partnered with Dr. Shanley over at Lurie and with Dr. Liz Heath at Rush and others in value-based care. And we're certainly going deeper with our providers to help achieve better health outcomes for patients at lower cost, and also ensuring that happens in a way that's financially sustainable, for providers. We're also investing heavily in our digital capabilities around care management. One of the things that we have done is curated a best-in-class portfolio of specialty vendors that can support services like diabetes reversal, which means that a lot of our employer customers who also have a lot of vendors knocking on their doors don't have to go through the efforts of trying to vet or experiment with those. We've leveraged our expertise in that particular space. There was some discussion related to utilization management. We're investing in those processes, especially on the side of interoperability, so we can improve the velocity of our medical necessity determinations, doing that in the workflow of our ordering providers, trying to reduce the hassle factors, but also reducing duplication of unnecessary services and ensuring that we can speed access to care in a responsible way. And also, I think, helping our patients and members navigate to high-value providers when they're seeking elective services, and also giving providers access to what the value chain looks like in their referral networks as they partner with other providers to help solidify care for patients. And the last thing I would say on this area is we're also active in addressing fraud and abuse. We certainly work with the government and other payers to combat fraud and waste. But the reality is we do have a lot of healthcare providers who are both caring but also willing to take advantage of the system, which also drives up costs for patients and insurance coverage. So it's a multifaceted effort that I think our organization and others are taking to help contribute to improving healthcare costs.
Thank you so much. Blake, I want to go to you on this. Just what are steps that providers like Rush can take to help address costs?
Yeah, and I think one of the biggest things to kind of keep in perspective is the cost is really being driven to the patient, right? And so a lot of what we're doing in our efforts at Rush is, one, helping patients navigate that cost on the front lines, right? So whether it be, trying to understand what their benefits are, whether it be trying to get them estimates beforehand, trying to navigate them to the appropriate care setting, the best cost for that patient, whether it be working through our financial counseling processes to see how we can assist the patient. Those are the things that we're doing directly to help the patient kind of navigate that. Within our ecosystem, we meet once a week around that patient experience. How do we make that the best for the patient? Help them understand. We at Rush were one of the first organizations to partner with Epic to implement an AI chat bot, right? And that bot works 24/7, 7 days a week. So if a patient is up at night thinking about that cost, they can get an answer pretty relatively quickly by going online and chatting with the bot. So we're just trying to continue to think through how do we help the patient navigate that cost. But internally, there's some things that we all have to do differently. So one thing is Rush is a 3-hospital system. We've been working very diligently to systemize our organization. And what does that mean to us? By looking at our contracts, looking at our labor, looking at pretty everything that goes around the cost of healthcare to see what we can do to make that more efficient. We've also standardized a lot of our processes, trying to look at even our EHR, our Epic system. We had 3 different service areas last year. We're now on 1. And I think it's 3 different variations of processes. Now we're trying to bring that down to 1 and cut some efficiencies, make it drive efficient, things like that. And then the other thing is just the investment in automation. I think, that's a buzzword right now in the industry. But we really are looking at that as how do we continue to leverage automation to scale the work that we're doing. Especially, I think the long-standing model is you have more patients, you gotta hire more people, right? You got more of this, you gotta, invest more. We're trying to use that automation to help us scale a little bit differently at Rush as well.
Fantastic. Dr. Shanley, what are your thoughts on this? Just kind of what can providers do in this space?
Yeah, that's, I think, one of the most important underlying questions to ask. What can I, as a provider, do? He can reduce the cost of drugs. He can do a better job of automation. We can get better contracting aspects of it. What can we do as a system that provides care? And so I would use an example, in fact, which we use 340B savings for in the community, which is what we call an alternative payment model structure. So we we have about 40,000 kids that are covered under Medicaid. And what we discovered many years ago is that unfortunately the zip code is more important to the kid's outcome than their DNA code. And so the social influences of health are critical for us to understand the context of their health activities. And so what we've been able to do is we look at them and identify if they have a social determinant of health that can be addressed or should be addressed. About roughly, don't quote me, quote the scientists that publish this stuff out of our group, but about 20% really don't have any issues. About 40% have one or two. They might need transportation to their office or access to their medication. And about 40% have a lot. And the model contracts as well with the federally qualified primary care providers. We provide the specialty care, and community-based organizations provide the wraparound services for that. It's a per member per month payment structure. And over the last several years, we've been able to demonstrate lower healthcare costs. We should also get to the point about not just talking about cost in this conversation, because that's not what medicine's about. It's about value. And so you've got a higher quality of healthcare outcomes at a lower cost. That is really good value. So that's one of the examples. I think the other area that we've used our savings to deploy into the community has been the maternal health aspect of it, and our young mom fetal baby program, in which we've been able to provide the right preventative services for mom, get them through the pregnancy without any preterm deliveries. And so we think about the overall implications on the reduction of healthcare costs in that population. It can be tremendous. And then from my perspective, again, yes, I'm wearing my pediatrician hat. If you're doing all that right in terms of health promotion early on, think about the unbelievable cost savings you'll have in the adult world. Okay? So if we're going to make investments, let's make them in kids, because you're going to get a long-term payoff. So that's, I think, things we control, and we have opportunities to try to reduce the cost of care.
Absolutely. And then Peter, I want to go to you from the manufacturer perspective. Just what can your members do in this kind of larger conversation to help address cost?
Well, all of our companies have supported alternative payment methods for our products to go to all providers, hospitals, clinics. It's something that is more, I think, in its infancy than it is anything, but it's something that we've all wanted to explore and have done. Thinking back to 2015, when hepatitis C, a cure for hepatitis C came online, a lot of the state Medicaid budget directors were very worried that we were basically going to bankrupt the system with this, because it was a $56,000 drug, but a cure. And within 3 or 4 years, there were multiple competitors. That price came way down. But some of the companies even offered, the state of Louisiana is a good example. They offered the state Medicaid program in Louisiana. They basically, if you give us X amount of money, we give you unlimited access to this drug on a contractual basis. And it worked out. It was a money saver for the state. It was obviously recouped our costs and made a little bit of money on our side, and that worked. So the more often that we can do stuff like that, and I know we're talking Medicaid and government payers, but that certainly will save the state as much as we can, or save those payers for those public programs much more. On the other side of everything, transparency has always been a big deal, been a big buzzword in healthcare for a very long time. A lot of that has been a spotlight that's been put on us for years, and we've argued that it needs to be on healthcare as a whole. Everybody needs to be part of that transparency spotlight, because the old saying is healthcare is a balloon. You squeeze savings somewhere, it's going to pop up somewhere else. That's just the nature of healthcare, with everybody contracting with one another, everybody interacts with one another from industry to industry within healthcare. So a little more transparency on how everything is done, whatever that might look like. We want to be part of that conversation. We absolutely still and continue to support the 340B program. Our only concern with that program is that the growth has just exploded in the last 15 years. And I think that fundamentally our companies who participate in that program, to make sure that we're getting vulnerable communities the medicines they need, is to know where that money is going to and what it's being used for at the end of the day. Not trying to place a burden on any of the providers or any of the hospitals, but really to have a better picture of where we need to be more targeted with this benefit, and making sure that it's getting in the hands of patients to bring down their costs.
Definitely. And Peter, I think you maybe looked at my notes, because you just answered my next 2 questions that I asked. But I want to get into the 340B a little bit more. Obviously, we've been hearing, those in the healthcare field have been hearing a lot about it for years now. those in the general public, I think, have been hearing a lot more about over the last 6 to 10 months or so here in Illinois especially. Just for a quick background, for those who aren't aware, there is legislation in Springfield that will do some reforms to the 340B program. It's currently in the House waiting for a concurrence vote. And Peter, I want to go to you just kind of on that legislation that's being discussed here in Illinois, just kind of your thoughts and just kind of where do you think the 340B program needs to go from here?
I mean, honestly, it starts with the transparency, but we also have to have a serious examination of the contract pharmacy arrangements that are within this program. So, you know, for a quick primer, 340B fundamentally created in the late 80s, but codified the law in 1992, where the pharmaceutical industry is providing discounted drugs to outpatient clinics, mostly in it for community-based care, FQHCs, community clinics. Over the years, that's kind of how it went. And because HRSA, the agency that oversees it, DC, is relatively small, I would probably argue underfunded, like a lot of agencies can be, basically has had no statutory authority to do anything to it. So everything's been done through regulation or sub-regulation. Expansion has happened. And these clinics don't have in-house pharmacies, so they need to contract with the Walgreens or CVS or whoever is in the neighborhood to make sure that these patients that are going to these clinics get their medicines at the discounted rate. Started to contract with those outside entities, and they were allowed a couple within a geographical region of that clinic. And then back in 2010, not long after the ACA, basically through regulation said, okay, go wild, you can have as many contracts as you want. And then we started seeing these massive contract pharmacy networks that were extending far beyond state borders for any hospital. And really just because it became a moneymaker for PBMs and for for-profit pharmacies. It's a massive part of Walgreens' business, it's a massive part of Walmart's business, CVS as well. And you know, honestly, those contracts, they don't necessarily squeeze the larger dish hospitals like Rush or anything like that, or Endeavor. But certainly the FQHCs and small community-based hospitals, they are spending far too much money on these contracts. Some of 340B is a money loser for these smaller hospitals. And there needs to be an examination of why those contracts aren't working, especially for the smaller rural providers, sole community providers. And that's something that they've been trying to do in Minnesota. Minnesota has a transparency report found in 2024 that there was $1.34 billion going into the state or coming to hospitals in the state on 340B, but only a small percentage of that money was making it to the smaller hospitals. So we need to have a better understanding of why and how, and if there's a way to fix that so that we don't have problems of hospitals shutting down or cutting services, or, you know, I know some of the more larger or the smaller systems say consolidating services, but if you move L&D out of one community, put it in another, what happened to that community that had labor and delivery but doesn't have it anymore? So that's a good start. Sorry.
No, I think that was a great little primer there. Dr. Shanley, obviously, you mentioned 340B earlier. I just kind of want to get your thoughts on, from the hospital perspective, just what you want to see in this program and what changes are necessary.
It can be quite complex. For me, I start conceptually being pretty simple here. Okay, so if you take the top 10 pharmaceutical companies in the world today, their profit ranges between about $44 billion to a high of $94 billion. Pfizer has the worst margin in the world at 12.5%. 12.5%. You show me a health system in Illinois that has a 12.5% margin, and I'll go work for them. That's the low. A high of 33%. So we're talking about billions of dollars of margin created by the pharmaceutical industry. And a small fraction of that business, this is just simple, a small fraction of that business is eligible for 340B savings. So that's the big picture. It can be very complicated, but that's the big picture, frankly. And the challenge is that if we don't keep it, even just the status quo, no one's asking to increase or expand it necessarily, but we want to make sure that the safety nets have, and the critical access hospitals have ongoing access to the pharmaceutical drugs that is happening. And if we limit and restrict them, that's what the current bill in the House is doing, is just to make sure that we maintain that constriction. And if we want to talk about the savings, if you talk to some of your local community health systems, the savings they get today from the 340B keeps them in business. If the 340B savings went away today, we would have additional closures like West Suburban and other ones. So it can be very complex and certainly transparency, look, it's a highly audited program, for goodness sakes. I mean, we report everything. So the transparency of what we're savings and where we deploy those savings, at least as our institution, to community benefit, you cannot question that. So I just think that we need to make sure that we're doing the practical right things when we think about the 340B program moving forward.
Great, Blake, anything you want to add on
I can't add any more to that. I think Dr. Shanley covered it very, very well. I think ultimately 340B is needed for our most vulnerable patients, right? I think we all are committed to being transparent. We all are committed to ensuring that we are applying those dollars the appropriate way, but it is needed. And I think to Dr. Shanley's point, if you look at any hospital's profit margin, you're doing really good if you're about 1% these days. So I mean, most organizations are just breaking even. So that's something to just kind of consider as you look at the bigger, broader picture, but it is important to see it for our patients.
Definitely, Dr. Robinson, can you hear us?
I can.
Wonderful, great. Well, I want to kind of switch gears a little bit. Obviously, the topic of transparency has come up a couple times now today, and I figure in Springfield you've heard the lawmakers discuss the idea of adding more transparency as a way to address healthcare costs. And I'm just kind of curious your thoughts on this. Just what are your thoughts from the insurance perspective on transparency? What does that look like to you, and how could that, in your perspective, address cost?
I think there's certainly a role for transparency, and I would say from multiple perspectives. It's not uncommon, even in the healthcare setting, as a ordering provider, to know what the cost of differences explicitly are between services that are ordered, or what's happening in terms of the cost and quality for folks that we're working with within the referral network. I do think that in many circumstances, patients can benefit from information on quality and cost as well. And so, one of the things that we've done is try to empower our members and patients with that information using our member rewards program, which helps give them information as they're seeking care with regard to the quality as well as cost opportunities. We also are in a process of working with some of our employers around deploying guided health plans so that they can, as an employer, take kind of a novel approach to curating a network of high-value providers and also embedding value in the benefit plan and copay structures for their employees. So I think creating transparency both on the provider side as well as on the patient side, I think, can be helpful in addressing some of the challenges around the value proposition in healthcare.
Fantastic, thank you. Blake, I want to go to you just on the idea of transparency.
Yeah.
What does that look like to you?
Yeah, I'll talk to it from a kind of patient perspective as well, right? So there's guidelines and rules around price transparency. We at Rush have taken it very, very seriously and make sure all of our price transparency files are aligned and up to date, and we are a leader in that particular space, make sure we're adhering to that regulation. But being transparent just in terms of the prices in our charge master is a lot different than a patient understanding what does that mean to them, right? Because you can see the line item charge or the line item price in our file master, but to a patient, you have to translate that to deductible and co-insurance and all those things that we all know as being patients, right? And so one of the things that we have really worked to do at Rush is not only make sure we have everything posted and all that, but when a patient comes in, we want to deliver an estimate to the patient and try to make sure that estimate is as accurate as possible to understand not only what is the price, but how does that apply to your benefits? What does that mean in terms of your deductible, your co-insurance? What are your options to pay? What if you can't pay? How can we help you with that? So I think from a patient perspective, transparency not only means from a clinical, maybe from a clinical, where's the quality of all of that, but you have to think when patients come to the hospital, they're very vulnerable, not only from a health perspective, but also financially, right? And really helping them understand what that means to them. So I think we can all do a better job of that. I think I always say healthcare is one of the last industries that you can go and have a service and not have a clue what you got on. You can't do that with one of the other services that you can go have that service and say, oh, I'll just take care of that later. You know what I mean? That's kind of how the healthcare is. So we have to do a better job of helping patients understand it up front, help them navigate that, and help resolve that for them as we go through that process.
Wonderful, great. Dr. Shanley, I want to change gears a little bit. It was briefly mentioned earlier that one of the potential drivers of cost is, increased consolidation that we're seeing in the healthcare space, among providers, among insurers, and what have you. And I'm just curious your thoughts on that, just kind of what you see, as consolidation, kind of where that is in the larger conversation here.
Yeah, so, I'll just have to use my lens at the regional and the quote-unquote consolidation that's occurring. I think, I do understand the business drivers and some of the reasons some of the bigger systems have tried to amalgamate and consolidate for some cost savings and other things. What we actually see in terms of, I wouldn't call it consolidation, we're seeing contraction. And what we do is really hard to do. And it's really hard to do it exceptionally well, because you need the people to be able to do it, and you need the volume to not only learn on, but also to be able to continue to stay still on. And with all these cost structures that we've been discussing, including the personnel costs to be able to do that, more and more institutions who don't only focus on pediatric services have found it very challenging to provide pediatric services. And in addition, we've had, as we went through COVID and folks began looking a little bit more clear in terms of the differential between Medicare reimbursement for the cost versus Medicaid, including meds, people realize, maybe we'll just stick with the Medicare and the adult meds, and we'll start to close the pediatric meds. And so that's really what we've seen throughout the market. We've seen a 40% reduction in pediatric meds over the last several years. And that's impeding the access that kids need to specialty care. And frankly, one of the observations that drove our decision to build a community hospital in Downers Road to be able to meet these access needs that were starting to be limited by this contraction. Now, broader consolidation in terms of where potentially multiple children's hospitals could aggregate, I think it's an intriguing model and something that a few of us across the country are looking at. Are there structures, are there infrastructure costs that might be able to be shared in ways that we similarly see systems buy up multiple hospitals and run their system? So I don't know, it's complicated because we're all dependent on Medicaid, which is a state-based program, and so going Medicaid across state lines becomes very complex. But I wouldn't close the possibility on that in the long run.
Absolutely. Peter, I want to go to you on this, and again, just kind of jumping around the different topics here before we run out of time. You were on a panel last year, some of you may have been there as well, discussing prescription drug costs. And a large part of that conversation was around the role of pharmacy benefit managers. For those who don't know, Illinois, the General Assembly and Pritzker signed legislation last year to regulate that side of the prescription drug chain. And I'm kind of curious your thoughts on how you see that legislation affecting some of these costs, and what more do you think there is to do on that front?
I mean, I think it was a great addition to the things that former leader Harris did a few years ago on reporting for PBMs in the state level. And I'm glad that Governor Pritzker took it up and signed his bill last year. I think overall a very excellent piece of legislation. I think from our perspective, it could have gone further, mostly in the fact of passing on those rebates to patients at the pharmacy counter. Right now, that language talks about going back to plan sponsors, and through consolidation, that's where you're seeing kind of that hiccup take place, because plan sponsors are now owning PBMs, and PBMs are owning plan sponsors. And I remember a hearing, I think in the U.S. Senate Finance Committee with Senator Elizabeth Warren from Massachusetts, this was 2-3 years ago, saying, you're basically handing a check from one side of the building to the other, and it's the same company in the same building, and that's all you're really doing when you're saying you're going back to the plan sponsor. So I think that still creates a little bit of a problem, but overall, I mean, I certainly applaud Governor Pritzker for taking that on and doing what he did. Same thing with dealing with some of the prior auth the year before. He's really done a lot of great steps for patient-focused initiatives in Illinois. And Illinois has always been ahead of the pack, I think, for a lot of states when it comes to patient-focused initiatives. One of our big issues has always been banning copay accumulator plans. For years, health insurers allowed for patient assistance from pharmaceutical companies to count towards a deductible for a patient, and then all of a sudden kind of stopped several years ago. So several states have been trying to reverse that so that it would count towards deductibles. Illinois was one of the first states to do that, and that was great. So I'm glad that that trend has kind of kept going forward as far as all the patient-focused initiatives.
Absolutely. Dr. Robinson, as we're talking about, legislation and some of the steps taken, I'm curious what you think from the insurance perspective. What should policymakers be looking at as they tackle this affordability issue?
Well, I'm not as familiar. Are you talking related to the PBM or separately?
Just kind of the larger sense.
Yeah. Well, I think, I would just kind of go back to some of my, opening comments there. I think certainly we've got to ensure that our focus is on improving the overall health of individuals, and that, the type of investments and focus that is needed on that across society. I think often we find ourselves sort of in different places and spaces related to that, but certainly those of us who are here on the panel here who are responsible for providing services for folks when they're ill and they don't have the health status that they desire, we see the need for that. And so I think when we talk about affordability, I think we've got to look at it much more holistically. And that definitely includes addressing things that are far upstream of the illnesses that patients may ultimately find themselves with. And I think that harkens back to the questions around, do we have a healthcare system or do we have like a sick care system? And we certainly need to ensure that we are, promoting those things that allow people to make, good choices regarding, their food and their activity levels and having safe environments to live, work, and play in, and all the things that really would help us have a healthy society, giving everyone an opportunity to be as healthy as possible, versus finding ourselves really grappling much further downstream with the implications of missing many opportunities to make our communities healthier.
Fantastic, thank you. What do you want to go through on this? Just kind of, what are some of the things that you think policymakers need to be looking at as they have these conversations about affordability?
Yeah, Dr. Robinson hit on something I think key, that early prevention from our patients, right? Dr. Shanley talked about it too from an early childhood perspective. But I always put myself in the lens of our perspective revenue cycle, right? Why do patients delay care sometimes, right? A lot of times it's because they either they feel like they can't afford it, right? They can't pay for it. Or even when they do feel like, okay, I'm gonna finally go get this test, right? I've been having this pain for a while, I'm gonna get it checked out. Then you have to get approval to even go get it checked out a lot of times, depending on what type of exam it is and all of that. So I think we really have to look at the barriers for a patient to get the health care they need. Not only the normal, foundation of things like eating right and working out, all of those things, but even when you identify a problem, you have the early symptoms, things like that, chronic illness. How do we get that patient in as soon as possible and alleviate any barriers administratively to get them there? So paperwork and authorizations and all these different things that are required. We have to eliminate that so patients can get that care as soon and as early as possible, and then continue to get that care where it's not being done at a very high level of cost or high care setting that could have been prevented. So I think that's a part of the affordability, and I think just on a foundational level, we in the healthcare setting, we are always trying to advocate for the patient. How can we help them afford this? Whether that be a no-interest loan, whether that be a payment plan, whether that be discounting. We all do that in a healthcare organization. So we do try to think through how we help them afford it, but the core of the issue is how do we get them to be seen a lot sooner in the process, and how do we maintain a more healthy
Absolutely. Or actually, Dr. Shanley, we'll start with you now. Kind of as we talk about, policymakers, we'd be remiss if we didn't mention some of the federal changes coming, as a result of PhRMA, whether or not be changes to the Medicaid program. And I'm just kind of curious what you think some of the changes coming down the pipeline, what this could mean to the larger conversation we're having here about healthcare affordability and the efforts you and your colleagues are taking on this.
Yeah, well, that's easy. It's a disaster. The proposed Medicaid cuts within HR 1, I think total somewhere for Illinois in the $57 billion range cut. That's a non-sustainable number for, to be fair. fair for what we do today. Now, as Derek and I and others have tried to share, I think where there are opportunities for us to change the model of care, we definitely want to do that and be able to provide higher quality of care at a lower cost structure. That Medicaid does need that. Medicare needs that. So, in fact, kids, just remember this: of all the Medicare budget, kids are only 20%. I mean, Medicaid, the whole Medicaid budget, kids are 20%. Okay? So we're underinvesting in kids as a country, and again, long-term cost savings. I have to touch on. I don't know if we're gonna go there, but the other cost structure that has something to say about the legislative structure in the state of Illinois is Med-Cal. The state of Illinois is circled by all of our partner states that have caps on awards and Med-Cal awards. And anybody know the story about Willie Sutton, why he robbed the bank? Because that's where the money was. You want to know why all the plaintiff attorneys in the country are coming to Cook County? Because that's where the money is. And so these nuclear settlements and frankly, it's not even the settlements per se, or it's not the jury claims that are made. It is the settlements that you end up talking to potential people about because you're so worried about a nuclear verdict coming forward. So we can be defeatist about this and say, the Supreme Court says it's non-constitutional. Or we can say, is this a major driver of cost in healthcare today? Yes. Is it going to impact the delivery of key services like obstetric care? Yes. Does it make sense that partner states have already done something about it and we've not? No, that doesn't. So can we have a serious conversation at the state level about what's needed to make sure that we change the Constitution in the state of Illinois to get this ridiculous, frivolous cost that has nothing to do with improving the well-being of our patients anywhere out of the system. So I think I know that's a big challenge. It's like the Chicago pension challenge, but we're still going to have a very bad and a sub-performing health system in the state of Illinois until we get that done.
Where are things with that, Shanley? Have you had any conversations with lawmakers? Kind of where are we at on that front?
Yeah, I mean, I think we're now starting educating the lawmakers on that, and we're trying to determine the best pathway by which we could actually institute those changes, because the Illinois Constitution has some aspects of it that need to be changed, and how necessarily to do that. But the Constitution of the state of Illinois, just like the Constitution of America, was made to be amended. Neither been amended in a while, but we can amend things. Especially if it makes sense and logical for what we want to do for our people in the state of Illinois.
Fantastic. Dr. Robertson, I want to go to you just as we kind of talk about some of the changes that are coming down the pipeline, and just kind of how are insurers preparing for some of the changes to the Medicaid program and some of the other, everything else that's in HR 1?
Well, we're continuing to work closely with the state and also working closely with providers. I think certainly there have been a number of things that have supported care in Illinois that are going to face some challenges, whether it's the hospital self-assessment and some of the other changes that we've seen to eligibility for Medicaid. And certainly we want to ensure that, Dr. Shanley talked about ensuring that you're actually able to have cost reimbursement that covers the cost of care that's being rendered. I think also it's important to ensure that as we see the population and Medicaid go down and the likely acuity or sickness of people who remain on the rolls go up, that MCOs remain in a solvent situation in terms of the reimbursement that they get from the states to then work with our providers. I think there's also concern about ensuring that the safety net infrastructure remains strong. You may have some hospitals that find it difficult to stay open. And we also can expect that there could be challenges with cost shifting from public payers more to the commercial side. And employers are important in this discussion as well. They provide coverage for 60% of adults in Illinois and 50% of Americans across the country. And so when we think about how to sustain the healthcare system, we also want to think about, those employers in our communities that are competing in a global economy that are also trying to ensure that they're able to maintain coverage at an affordable rate for their employees. And so when we think about all the things that are happening across the healthcare system and our focus on value, we want to ensure that it's not lost on us that we've got to handle the delivery of care in a fashion that's responsible for all parties, especially those that need care and those that are helping ensure that that care is accessible.
Fantastic, thank you so much. Somehow we're only at 9 minutes till 10, so I do want to open it up here for some questions from the audience. If you have any questions, please just raise your hand and I'll call you as I see you, and just let us know who you're directing your question to. Oh, well, there we go. Last call for any questions? All right, so it looks like I need you guys for another 9 minutes.
They were supposed to give them 30 seconds.
That's right.
Yeah. Wonderful. Well, let me get my notes here ready. I wasn't expecting that, so I'm trying to figure where to go from here now. So I do want to go to something that Dr. Robinson kind of mentioned, and Dr. Shanley, I'll go to you on this one. We see in Elmwood there's a larger emphasis on the idea of value-based care payment models, and I'm just kind of curious your thoughts on that and how that could affect cost of consumers.
Derek, do you want to go first, or do you want me to go?
Sure, happy to jump in. I made another Yeah, absolutely, Tom. Happy to chime in. So we think value-based care is a place where the relationship between the providers, the payers, and the patients can really go deeper. And so I think it's something that's important for us to continue to address collectively. Across our company, we have about 49,000 providers that are participating in our value-based care arrangements across the 5 states affiliated with Blue Cross Blue Shield of Illinois. And we've got about 40% of our membership that are in value-based care arrangements. What we see in the value-based care and ACO arrangements, we see improved quality outcomes. We've seen about 10 to 25% reduction in inpatient admissions. We see ER utilization lower 10 to 15% with those providers, and we also see that preventive care visits are up 5 to 20% across those providers. And so I think when we work diligently to align the incentives in a way that promotes higher quality care, more timely care, and more efficient care, it benefits us all. And earlier, Ryan, you asked about what happens when we see consolidation occur. I think there are positive reasons for a consolidation. You can have better coordination of care, you can have shared administrative expenses, but part of the challenge with consolidation and the downsides of it, in addition to what Dr. Shanley noted earlier in terms of reduction in lower margin, lower volume care, is that you also begin to see the prices go up for care. So you may have a outpatient ambulatory surgical center or an infusion center or an imaging center that then becomes part of a larger health system benefit. You can have greater coordination, but then you see the prices go up without a commensurate increase in quality of what you're getting. And so when we think about value-based care, it helps us focus less on where are the opportunities for us to raise prices and increase margin. By consolidating and coming together allows us to come together across different types of care to ensure that we are doing what meets the members, the patients' need best, and also doing it at a price that does not financially challenge the member, financially challenge the employer that's providing the coverage. And I think that's something that's important that we want to continue to do. I also want to just acknowledge it's challenging for providers that sit in both spaces, where you've got, I think Blake noted earlier, a number of different health insurance companies that, they may contract with, they may have very different BBC programs, and you're living in both worlds of both fee-for-service and value-based care. And so I think the further we can get to more of a value-based care model, I think it'd be easier for us to deliver greater value across the healthcare delivery system.
Yeah, totally agree with everything Derek said. And I think what will, he said something really key, aligning the incentives of all three parties, right? Certainly the provider and the patient, and then if there's a payer involved in that aspect of it. So that is really key. And it's really thinking very differently about the American healthcare system, which is not as I think he stated, it's currently it's the American disease system. We want to get to where we're all upstream and we're doing health promotion. That's the way that we start to impact the overall cost of the care. And so what, and I believe, we didn't really talk about technology, the application of technology, what that'll likely do in terms of some of the cost structure. If we transform the models of care and we transform the operational businesses that we're doing today, so that's a big if. But the opportunity for us to be more, what we're describing as precise in the alternative payment structure, so if you'll recall what I said a few minutes ago, that 20%, that per member per month cost is lower than that middle 40%, which is lower than that top 40% in terms of the cost structure. So can we figure out a more real-time model that allocates the expected cost of care to the various levels of acuity, if you will, especially in terms of managing chronic illnesses. And as we've started to do that, to Derek's point that he raised, we are seeing reduction in the use of the emergency department. We're seeing reduction in what are called avoidable acute care admissions for chronic diseases like asthma and diabetes. And so I personally believe that that's got to be the future of the main cost structure of the American healthcare system, because the way the costs are escalating today is not sustainable.
Dr. Shanley, I just want to make a quick note that we almost made it through an entire minute on talking about AI and technology for the first time in a while, but got there just in the nick of time. Peter, what do you want us to kind of talk about technology? Just what's going on in the drug manufacturer space with regard to technology? Kind of what is the role there?
I mean, it's still something that's under a lot of discussion among the companies on how best to apply things like AI. I think the most basic application, at least from our end, is maximizing clinical trials, identifying patients, trying to get more clinical trials online, and frankly, I think we do a pretty good job right now, but if AI can assist on that, that'd be great. I'm sure there are companies that are using AI to identify where to start on some of the new therapies and new cures that they're working on. And it's still, I mean, I would say it's still kind of in its infancy in our industry, and the best way to apply it. So that's what we're. Battery died. Oh, I talked it out. There we go. So it's still something that our companies are working diligently on to figure out the best way to apply it for what we do, quite frankly.
Sounds great. We are 1 till 10, so I'm going to go ahead and ask each of our panelists one last question. And Dr. Ross, I'm going to go with you first. I know you very appreciative of you joining on the call with us today. I think the Zoom event is about to end in a minute, so in about 30 seconds or less, I wonder if you just kind of tell us your thoughts on where this conversation goes next. Where do you think this discussion on healthcare affordability should or needs to go next?
Well, Ryan, thanks for the opportunity to be with you all. There's a lot of complexity in healthcare delivery. We certainly have an obligation to make that as simple as possible for patients that deserve to be healthy and have access to care. I think we have to continue to work collaboratively across the different sectors and domains that we represent here today. And I think if we continue to work together, we can make progress. So I appreciate the opportunity to be here with the other panelists.
Thank you so much. Blake, let's go to you. Just kind of where do you see this conversation going next?
Yeah, Dr. Robertson just said it perfectly. I think 2 words I always walk away with when I think about the healthcare ecosystem, right? We need to simplify all the complexity, right? And then also collaborate. We cannot solve this challenge independently as a hospital, as a pharmacy, as an insurance company, or even as patients, right? So we got to all work together to look at our whole system and try to simplify that as much as possible.
Dr. Shanley, what are your thoughts here?
Totally agree, Blake. Well, look, I reflect, I stepped into my role in December of 2019, so May of 2026 years ago, the world was quite different. there were people out on balconies banging pots and pans, and the hospitals and their personnel were heroes. Those are the same personnel and the same hospitals we have today, and somehow they're being responsible for the cost structure and the cost challenge and affordability of American healthcare. I think frankly that's wrong. They're still heroes. They don't control, and we don't control much of the cost drivers to the affordability challenge that we have in the American healthcare system. So to Blake's point, we do need to partner, we do need to collaborate and do our part, but also work with others in terms of addressing that. So it's a serious issue, for sure. But for a few legislators on the Hill and a few pharma companies to change the narrative that somehow the hospitals and the health systems are the bad guys here is absolutely wrong. I think we need to change that narrative and make sure that we're serious about all the comprehensive drivers of the healthcare affordability and address them together.
Peter, you had the opening words, and I'll get you to have the closing words.
Again, the collaboration among all the industries in healthcare, like I brought up the healthcare balloon, we all have to be part of the solution. That's something that we've always, in every conversation at the state, local, and federal level, and wanted to be a part of. Having everybody in the room to be part of the solution is very important. I hope we explore more with alternative payment models for payers, for hospitals, for anybody who's trying to get to stock our medicines. Our companies are doing everything they can to expand their patient assistance programs. We launched americasmedicines.com a couple months ago, and this was a clearinghouse for all of the patient assistance programs out there. You go in as a search engine, plug in the name of the drug, and it'll bring up the discounts our companies offer for those drugs, some at no cost, some at very, very little cost. Some companies are looking at direct-to-consumer models, especially on GLP-1s right now. Who knows what's going to happen for the remainder of this administration in DC and beyond, but we'll stay optimistic, I guess. But that's something that all of the companies want to explore, be a part of, anything that's going to bring down costs to American consumers and patients.
Fantastic. Thank you so much to our panel for joining us today. It's a wonderful way to start our meeting.
Thank you so much. I appreciate it.
Great. Just want to let everyone know that hopefully they'll link us up on the virtual event next Wednesday. We'll be at the increased focus. Oh, you guys can go ahead. On the increased focus on men's health efforts. More information on that can be found on our website and our newsletter. And with that, hope you all have a great rest of your week. Thank you so much.